Vale, tanto voy എല്ലാവരും ജോയിൻ ചെയ്തിട്ടുണ്ടോ? സ്റ്റാർട്ട് ചെയ്യട്ടെ.
ഓക്കെ മാം.
ഓഡിബിൾ ആണോ? കേൾക്കാമോ നന്നായിട്ട്?
യെസ് മാം.
So today's topic is thrombocytopenia and immune thrombocytopenic purpura. So we will be dealing with first we will be seeing what is thrombocytopenia, and then we will move on to immune thrombocytopenic purpura. So first about the hemostasis process in our body, what happens during the process of hemostasis. The process of hemostasis means what our body does to control bleeding. So this shows there are 99 people. So I think maybe 98 may be present. 98 alkar undavullo. So I will be taking the attendance.
Zoom il 100 പേർക്ക് കേറാൻ പറ്റുള്ളൂ മാം.
ഓക്കെ, അപ്പോൾ
ബാക്കിയുള്ളവർ യൂട്യൂബിൽ ലൈവ് സ്ട്രീമിംഗ് ആയിരിക്കും.
അപ്പൊ നിങ്ങൾ അറ്റൻഡൻസ് തരുമല്ലോ അല്ലേ?
ആ യെസ് മാം.
So the process of hemostasis means our body is responding to a vascular injury or an endothelial injury. So what does the body do to stop bleeding? That is what is known as hemostasis. So there are two phases for hemostasis. First is the cellular phase and next is the fluid phase. Cellular phase is the one in which the platelets come into action. So when there is a vascular injury, the endothelium will release bone Willebrand factor I'm sure that all of you have heard about von Willebrand factor. And so that is released from the vascular endothelial cells. And this von Willebrand factor, on one side, it will bind to the endothelium, and on the other side, it will bind to platelet. So the platelets will come and bind to the von Willebrand factor. So on that process is known as adhesion of platelet. So that is platelet adhesion. Then what happens? The platelet will get activated and it will release certain factors from the granules present in them. And this factors will cause more platelets to come and attach to the initial platelets. And this process is known as aggregation. So first there is platelet adhesion to the von Willebrand factor, then platelet activation and release of granules, and then so many other platelets will come and adhere to this initial platelets, and that is known as platelet aggregation. Okay, so there are these three things are the functions of platelets. And after this, the coagulation cascade will begin. That is the intrinsic coagulation pathway and the extrinsic coagulation pathway. And that will result in finally a fibrin flow. And that is how the blood flow is formed to stop bleeding. Okay, so that is the hemostatic process. I hope it's clear. So that is the function of platelets in our body. So platelets are very important to stop bleeding. So when there is a deficiency of platelets, that will naturally result in bleeding in different forms. It can be minor bleeds, or depending upon the severity, it can be major bleeds also. So what is the normal platelet count in our body? Ajila, tell me, what is the normal platelet count in our body? Ajila. Roll number 7, Ajila. Ajila ile. Roll number 14, Amy Abraham.
Yes, ma'am.
Roll number 14, Amy Abraham, or no?
Yes, ma'am.
Okay, so what is the normal platelet count in our body?
1.5 to 4 lakh.
Okay, very good. 1.5 to 4 lakh is the normal platelet count in our body. So what is thrombocytopenia? It is platelet count less than 1.5 lakh per milliliter cube. So thrombocytopenia is defined as platelet count less than 1.5 lakh per milliliter cube. So what are the causes for thrombocytopenia? So now we are going to see what are the major causes by which platelet count is decreased in our body. First is immune. That is, by immune mechanisms, the platelet count is destroyed. That is, antibodies are acting against the platelets and destroying them. That is what is known as immune type of thrombocytopenia. So it can be either autoimmune, that means our body is producing antibodies against the platelets of our own body, or it can be alloimmune, that is, antibodies which are formed in some other place is acting against the platelets of our body, or it can be because of drugs. Okay, so certain drugs act via immune mechanisms and certain drugs act via non-immune mechanisms against platelets. So first is autoimmune. Autoimmune means our own antibodies are attacking our platelets. This can be seen in ITP, that is immune thrombocytopenic purpura, about which we will be discussing today in detail. Then in systemic lupus erythematosus also we can see autoimmune thrombocytopenia. Antiphospholipid antibody syndrome, APLS or APLA. Then Evans syndrome. Evans syndrome means it is autoimmune thrombocytopenia with autoimmune hemolytic anemia. The combination of autoimmune hemolytic anemia with autoimmune thrombocytopenia is known as Evans syndrome. Then that is ES. Then we have common variable immunodeficiency, another condition in which the antibodies of our body are acting against platelets. So these are apart from drugs, the major cause of thrombocytopenia are actually immune mechanisms, and among that, autoimmune is more common. Then next is alloimmune. Alloimmune means antibodies from elsewhere are attacking our platelets. So it can be neonatal alloimmune thrombocytopenia, NAIT. That means the antibodies from the mother are acting against the platelets which are in the newborn. So the antibodies, they get entry into the baby's blood. It may be through the placenta. and they will attack the platelets in the baby, and the newborn baby will be presenting with thrombocytopenia. That is neonatal alloimmune thrombocytopenia. Then PTP is post-transfusion purpura. That means when we are getting transfusion from someone, or we are getting transfused blood, and that blood contains some antibodies, and that are attacking our platelets. That is post-transfusion purpura. Then drugs, that is heparin. Heparin is the drug which acts via immune mechanisms to cause thrombocytopenia. That is heparin-induced thrombocytopenia. Okay. Next is non-immune mechanisms. Non-immune mechanisms, mainly it is, first it is according to the age also. So in newborn period, there are many conditions which causes thrombocytopenia, and other ages there are other conditions. So in the newborn period, what are the non-immune causes of thrombocytopenia? First is torch infections. So what is torch? Expand torch. Roll number 133, Junaid. Junaid, tell me what is torch? Expansion of torch. T-O-R-C-H.
And toxoplasma.
Okay.
Rubella.
Okay.
Cytomegalovirus.
Okay.
Haemophilus influenza.
No, it is herpes. Herpes simplex.
Yes, ma'am. Herpes simplex.
Right. So that is torch infections. Then maternal diseases. Even if the mother is having SLE also, the baby can develop thrombocytopenia. Then birth asphyxia, respiratory distress syndrome, necrotizing enterocolitis. All these are conditions in the newborn period which can cause thrombocytopenia. Then any age, infections can result, especially viral infections, sepsis, all can cause thrombocytopenia. Disseminated intravascular coagulation. That means the body is in excess coagulation is happening in our body, and that will deplete all the platelets and result in thrombocytopenia. Then thrombotic thrombocytopenic purpura. Then hemolytic uremic syndrome. Both are the same spectrum, hemolytic uremic syndrome and TTP, thrombotic thrombocytopenic purpura. Then Kasabach-Merritt syndrome. So what is Kasabach-Merritt syndrome, anyone?
What is hemangioma with thrombocytopenia?
Okay, who told that? What's your name?
I'm Lakshmi.
Okay, very good. That means hemangiomas are cavernous hemangiomas are present in the liver, spleen, and other internal organs, and they will cause destruction of these platelets, and that will result in thrombocytopenia. That is what is known as Kasabach-Merritt syndrome. And also hypersplenism. That means when the spleen is very much enlarged, like in other conditions, like when there is a tropical splenomegaly or something like that. So when the spleen is very much enlarged also, it can consume the platelets and result in thrombocytopenia. Then certain drugs. So which are the drugs which causes thrombocytopenia other than heparin? By non-immune mechanisms, the drug which causes thrombocytopenia are the common antibiotics that we use, like penicillin, some cephalosporins, then sulfonamides, and very importantly, linezolid. So thrombocytopenia is an important complication of using linezolid. So when a patient is started on linezolid, we have to monitor the platelet count. Then there is quinine and all, okay, that we use for malaria. So these are the causes mainly. Then some hereditary causes are there, like Bernard-Solier syndrome, Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome, what all other findings will be there other than thrombocytopenia?
Eczema, recurrent.
Okay.
Then recurrent infection, immunodeficiency.
Okay. Okay. And how will the platelets be other than thrombocytopenia?
Microplatelets.
Yeah, microplatelets. Very good. So the platelets will be small in size, and also their number will be less. That is what is happening in Wiskott-Aldrich syndrome. And apart from that, the patient will be having eczema, and also there will be recurrent infections because of immunodeficiency. Okay. Then we have May-Higlin abnormality. May-Higlin abnormality is a condition where the neutrophils as well as platelets are affected. Then we have von Willebrand disease type 2B. So there are three types of von Willebrand diseases, type 1, type 2, and type 3. And out of that, type 2B is associated with thrombocytopenia. Then conditions which causes impaired production of platelets, that is aplasia or dysplasia. So it can be some chromosomal abnormalities. Then some syndromes like thrombocytopenia with absent radius, that is TAR, thrombocytopenia with absent radius. These patients will be having absence of the radius bone also. Then congenital amegakaryocytic thrombocytopenia, Fanconi's anemia, dyskeratosis congenita. All these are dyserythropoietic these are conditions in which the bone marrow is not functioning normally. So as a result of that, different cell lines can get affected. All the cell lines, that is WBCs, RBCs, and platelets can get affected in these conditions. That is congenital amegakaryocytic thrombocytopenia, mainly Fanconi's anemia and dyskeratosis congenita. And also conditions where there is marrow failure, like myelodysplastic syndrome, myelofibrosis, and also Pearson syndrome. Pearson syndrome, here we can see along with this there can thrombocytopenia, there can be pancreatic insufficiency also in Pearson syndrome. Then marrow replacement by some other tissue or by blast, so that the normal megakaryocytes are limited to very less number, and normal platelet production doesn't take place. Like in leukemia, the marrow is replaced by blast cells. Then solid tumors, which can metastasize to the bone marrow. Storage diseases like glycogen storage disease and all. Then histiocytosis and also osteopetrosis. In all these conditions, the bone marrow is replaced by abnormal tissue, causing decreased megakaryocytes and decreased platelet synthesis. So these are the major causes of thrombocytopenia. In this class, we will be discussing mainly about immune thrombocytopenia or immune thrombocytopenic purpura, ITP. So that is the most common platelet disorder which causes bleeding in children. Okay, so we will be discussing about ITP. First of all, what is ITP? It is a clinical syndrome manifested as bleeding tendencies due to decrease in the number of circulating platelets in the absence of other disturbances of hemostasis or coagulation. That means there should not be any clotting factor deficiencies. There should not be any von Willebrand factor deficiency. So if all the other disturbances of hemostasis or coagulation is ruled out, we can, and there is a decrease in the number of circulating platelets, then we can say that the child is having ITP. So ITP, that is immune thrombocytopenic purpura, is basically a diagnosis of exclusion. Okay, so we have to exclude other disorders. It is we have told all the causes of thrombocytopenia. So we have to think about all that. And we have to exclude, we have to clinically as well as by some limited investigations, we have to exclude those conditions, and then only we can reach the diagnosis of ITP. It is a diagnosis of exclusion. So ITP is an acquired condition, that is, it is immune mediated. It is mediated by antibodies, and it is autoimmune. That means our body is producing antibodies against the platelets. And in ITP, the cutoff for thrombocytopenia, earlier it was 1.5 lakh, like generally what we take as thrombocytopenia. But after some recent modifications, we have taken it as less than 1 lakh, because generally 1 to 1.5 lakh, they don't produce much of any problem. There won't be any bleeding in children who are having platelet count which 1 to 1.5 lakh. So we have modified the platelet cutoff to less than 1 lakh. So in ITP, thrombocytopenia is platelet count less than 1 lakh. Then epidemiology, the incidence is around 1 in 20,000 children. It usually occurs around 1 to 4 weeks after exposure to common viral infections. That is seen in around 65% of cases, not in 100%. But we can get history of the viral infection around 4 weeks back in most of the children with ITP. And the most common virus implicated is EBV, that is Epstein-Barr virus. And the peak age for incidence of ITP is 1 to 4 years. That is smaller children. So it is in the early childhood, 1 to 4 years. And males and females have equal incidence. It is not more in any gender. So what about the pathogenesis of ITP? What happens in ITP? Our body is producing certain antibodies. It may be because after a post-viral infection or even otherwise. We don't know what is the exact mechanism. So earlier it was known as idiopathic thrombocytopenic purpura, because we still don't know what is the exact mechanism by which these antibodies are produced in only certain children. But now we are calling it immune thrombocytopenic purpura. So these autoantibodies that are generated in our body will be acting against platelet surface antigen, and this surface antigen is glycoprotein 2B3A complex. So there are certain surface antigens for platelets, 1B9, 2B3, all these have different functions. And antibodies are produced in IgP against glycoprotein 2B3A complex. And what happens is this antibody-coated platelets, they will be identified by the splenic macrophages and they will be destroyed by this splenic macrophages. So the antibody-coated platelets will be destroyed by the splenic macrophages, resulting in thrombocytopenia. So here you can see these are in the lower part, we can see the bone marrow where the megakaryocytes get converted to platelets, and these platelets are released in the circulation and they get bound by antibodies, autoantibodies, and this antibody-coated platelets, they are recognized by the macrophages in the spleen and they get destroyed by these splenic macrophages, resulting in thrombocytopenia. So this is an older experiment known as Harrington Hollis birth experiment. That means it was done long back in 1950. That is, there was a postulate that was made by a scientist called Harrington, and he postulated that antibodies are working against the platelets in our body and producing thrombocytopenia. In order to prove that, in a patient, he received transfusion from a patient with IgP, and within 3 hours, his platelets drastically dropped, showing that he had received some factor from the other patient which attacked his platelets. And then the platelet count remained low for some days and then it gradually improved. So this is an experiment which indirectly proved that antibodies are responsible for IgP, and that is Harrington-Hollingsworth experiment. So certain definitions. So in your OP guide, the classification for IgP is still the old one. It is not the new classification. So this is the latest classification for IgP, and you have to learn this only. So in your OP guide, IgP is classified as acute and chronic. That is, if the bleeding episodes are resolving within 6 months, it is acute IgP. And if it is lasting more than 6 months, it is chronic IgP in OP guide. But that is the old classification. Now we don't follow that. We have to follow this one. So certain definitions in IgP. First of all, about the platelet threshold. The platelet threshold is less than 1 lakh. 1 lakh per millimeter cube. That is what we take as the definition of thrombocytopenia in IgP. Primary IgP means there is absence of secondary causes. There is absence of secondary causes to account for thrombocytopenia. That is, it is a diagnosis of exclusion. I told before, we have to exclude other causes and we have to reach the diagnosis. We don't have a single test which is diagnostic of primary IgP. We are making a diagnosis of exclusion. Then a secondary IgP means immune thrombocytopenia due to disease or drug exposure. I told before, what are the causes of immune thrombocytopenia? It can be because of SLE, it can be because of APLA syndrome, it can be because of certain drugs like heparin. All these can cause immune thrombocytopenia, and these all are secondary immune thrombocytopenic purpura. And when these causes are not present, it is primary. Then what is severe IgP? Severe IgP means when there is severe bleeding, regardless of the platelet count. So here we tell the severity based on the bleeding. It's not based upon platelet count. So whatever be the platelet count, if the patient is having severe bleeding that needs treatment, then it is severe IgP. And what is newly diagnosed IgP? So this is the recent classification. That is, IgP is divided into newly diagnosed IgP, persistent IgP, and chronic IgP. Okay. So first is newly diagnosed IgP. That means from the time of diagnosis to 3 months. That is from the period which we diagnose IgP to 3 months. So that is what is known as newly diagnosed IgP. And then if the bleeding is persisting beyond 3 months, but it is resolving within 1 year, that is 12 months, then it is known as persistent IgP. So we have a new terminology here. Earlier it was acute and chronic IGP. Now it is newly diagnosed IGP, persistent IGP, and chronic IGP. So if the bleeding episodes resolved within 3 months, no further bleeding, then it is known as newly diagnosed IGP. If it is extending beyond 3 months, but it is resolving within 12 months, it is persistent IGP. If it is lasting more than 12 months, then it is known as chronic IGP. Okay. So this bleeding can be anything. It can be skin bleeds, it can be mucosal bleeds, anything. So if it is before 3 months, 3 to 12 months, and after 12 months, that is the most recent classification. We have to know that. So clinical presentation. So how do the child present to you with IGP? So the child will be previously well. There will be no significant past history. There will be no fever, no history of loss of weight, born pain. So loss of weight and born pain are very important aspects that we have to ask in history because they are all suggestive of a malignancy. So whenever there is a decrease in one of the cell lines, one or more of the cell lines, always we have to keep malignancy in our mind because the bone marrow infiltration is one of the reasons for decrease in one of the cell lines. So whenever the child is presenting with thrombocytopenia, we have to rule out malignancy. We have to ask for symptoms of malignancy like loss of weight, bone pain, and also any history suggestive of involvement of other cell lines like recurrent infections and all. Okay. Then recent onset of symptoms. There will be generalized petechiae, purpura, and there will be bleeding from gums and mucosal surfaces. So purpura and petechiae are skin bleeds. If it is less than 3 millimeter, it is known as petechiae, and more than 3 millimeter, it is known as purpura, till 10 millimeter. And there will be mucosal bleeds also. Apart from skin bleeds, there can be mucosal bleed, that is from gum, from other mucosal surfaces, epistaxis, hematuria, and rarely intracranial bleed. So severe bleeding like intracranial bleed is very rare, less than 3% only. So the blood routine investigations that we do and the blood film, that is the peripheral smear, is consistent with the diagnosis of IGP. The patient will not have anemia, leukopenia, or blast. So if any other cell line is affected, if the patient is having anemia, or if the patient is having leukopenia, we have to be very careful before labeling the patient as IGP because we have to be very certain that the patient is not having an underlying malignancy. Then there will be no hepatosplenomegaly, there will be no lymphadenopathy. These again are indicators of a malignancy or some other diagnosis other than IGP. Then the bleeding will be usually mild, and usually the bleeding is significant only when the platelet count is less than 20,000. When the platelet count is 20,000 to 50,000, there may be petechiae, ecchymosis, and all can occur when there is a mild trauma. Usually children will be running around, so they will be having mild trauma and they will be developing skin bleeds. That is when the platelet count is between 20,000 to 50,000. If it is below 20,000, they can develop more severe bleeding like mucosal bleeds, epistaxis, gum bleeds, hematuria, and if, in some cases, rarely it can cause intracranial bleed also. So these are examples of the different types of bleeds. You can see there is skin bleeds are there, petechiae and purpura, and in the lower right picture, you can see there is bleeding from the mucosal surfaces, from the oral mucosa. So this is how the child will be presenting to you. Then we have to think whether it is some other diagnosis. We have to think about an alternate diagnosis when certain features are present in the child. Like if that is the diagnosis of IGP is unlikely when it is a very young age group, that is less than 2 years, then we have to be very careful when the child is being labeled IGP. When there is a family history of thrombocytopenia or bleeding, like it can be, if it is a male child, we may have to think about some coagulation disorders like hemophilia. Then we may have to think about some other familial causes like syndromic thrombocytopenia. Then significant lymphadenopathy is there, hepatosplenomegaly is there. All these are suggestive of some other diagnosis, and we have to rule out malignancy in these cases. And in some children, we can see mild splenomegaly. Anemia disproportionate to the degree of bleeding. So when there is bleeding, there will be some amount of anemia. But if there is a severe anemia, it is unlikely to be IGP. Then if there is leukocytosis or leukopenia, that is the WBC count is also affected. and deranged floating spleen, that is the PCNR and APTK is abnormal. That means the patient is having some problem in the coagulation cascade also. So it may not be an ITP. And if the patient is generally unwell, if the patient is sick looking, generally the patient with ITP will not be sick. They will be well. Even if they are having bleeding manifestations, they won't be sick. So if these features are present in a child, then you have to think carefully whether it is ITP or not. Then about the outcome of ITP, what happens? Only in less than 3% cases there will be severe bleeding, and spontaneous resolution occur in around 70 to 80% within 6 months, but it can occur even after the first episode itself. Spontaneous resolution occurs in most of the children. Chronic ITP develops only in 20% cases, but when it is adolescents who are presenting with ITP, there is more chance, around 50% chance to become chronic. And the therapy doesn't appear to affect the natural history of disease. That we will come to. That is, we don't treat every case with ITP. We don't give medicines for every case of ITP. Some cases we observe. So even if we don't give medicine, that doesn't mean that the child is not having a greater risk of progressing to persistent ITP or chronic ITP. So regardless of the treatment that we are giving, the child will be having the same natural history of the disease. So some other terminologies. First is steroid-dependent ITP. That means in order to maintain a platelet count more than 30,000 and to avoid bleeds, the child has to be on steroid for at least 2 months. Then it is known as steroid-dependent ITP. That is, the child has to take steroids for 2 months at least in order to stop bleeding and bleeding manifestations and the count will go above 30,000. Then what is complete response? Complete response means the platelet count has become normal. That is, it has become more than 1 lakh. There is no diagnosis of thrombocytopenia. That is complete response, and the child will be having no bleeding. Response means it is not complete, but there is response if the platelet count has gone above 30,000. And along with that, there should be twofold increase in the platelet count from the baseline. So when the child is presenting with a platelet count of 15,000, say, or 20,000, and if the platelet count is going above 40,000, that means it is a response. That is, there is a platelet count of more than 30,000 and it has increased twofold from the baseline platelet count. And along with that, the patient should not have any bleeding. That is what is known as response. And no response is when the platelet count is less than 30,000, or there is a less than twofold increase, or if the child is having bleeding. And what is refractory ITP? So all these things, that is response, no response, and complete response, we are assessing after the time period of treatment or after the time period of observation. So how the child has progressed, that is what we are assessing by this terminologies. Then refractory ITP means failure to achieve at least the response or loss of, that means the child has underwent splenectomy. Then we told that the splenic macrophages are the culprits here. They are attacking the platelets. So in chronic cases and very difficult to control cases, we do splenectomy. And even after splenectomy, the child is not achieving a response. Or after achieving response, again the child has gone into thrombocytopenia. And we have to again give other treatment to control bleeding. Then that is known as refractory ITP. That is ITP not improving even after splenectomy is refractory ITP. Then what are the investigations to be done in ITP? First of all, we have to do the platelet count actually. So when a child is presenting with bleeding, you have to do a complete blood count. When the child is coming to you with certain skin bleeds, there are some echymosis, some purpura, or some mucosal bleeding from the mouth or the nose, or something like that. First thing that you have to do is you have to do a complete blood count. So in ITP, there will be thrombocytopenia. The platelet will be less than 1 lakh. The hemoglobin will be usually normal. And if there is a profuse bleeding, the hemoglobin can be reduced proportionate to the bleeding. The WBC count will be normal. And the peripheral smear will show normal platelets, or there can be an increase in platelet size. That means because the platelets are being increasingly destroyed, the bone marrow is producing more and more platelets. And since the body needs more platelets, they are releasing more immature platelets into the circulation. So the platelet size will be slightly increased than normal. That shows that there is a rapid turnover of platelets. Then if the child is having persistent ITP, that is if the ITP is lasting for more than 3 months, then only we have to do other investigations. like, or we have a clinical suspicion that it is not IGP, it is something else. If the child is having a splenomegaly, if there is a family history of some disease, or if there is a suspicion of hepatitis, in those cases, we may have to do other investigations also, apart from the blood count and peripheral smear. Otherwise, for a simple case of IGP, if we are satisfied that it is IGP, then we don't have to do other investigations, just a complete blood count and peripheral smear. And if it is a persistent IGP as well as chronic IGP, we have to do bone marrow. And what will the bone marrow show? It will show megakaryocytosis. That is because the platelets are being destroyed, the bone marrow will work more and more and produce more megakaryocytes, and that will cause megakaryocytosis. And bone marrow, we usually do when there are atypical features. Like if we are suspecting a malignancy, we are suspecting some other bone marrow failure syndromes or any congenital conditions like Fanconi, like that. If we are suspecting something like that, we do a bone marrow. Then ANA means we do that for ruling out certain autoimmune conditions. Anti-nuclear antibody we do in children or adolescents when we suspect SLE, systemic lupus erythematosus. We can do ANA. Then HIV testing in high-risk population. Direct Coombs test to rule out Evans syndrome. So Evans syndrome, I told you earlier, it is autoimmune hemolytic anemia with autoimmune thrombocytopenia. So that is in those cases, the direct Coombs test will be positive. So if there is an anemia also, and there are features of hemolysis in the peripheral smear, then we have to do a direct Coombs test to rule out Evans syndrome. Then immunoglobulin G, that is ELISA test to identify if there is an H. pylori infection, if there is HBsAg, if the child is HBsAg positive or anti-HCV antibody. So in hepatitis C, hepatitis B, and also H. pylori infection, there can be chronic or persistent IgP. These are secondary causes for IgP. So we have to rule out that also. So this is a picture of peripheral smear and bone marrow. The left one is a peripheral smear. You can see a single megakaryocyte, which is large in size. And that is it's not megakaryocyte, it is a platelet. Platelets are larger in size. And in bone marrow, you can see megakaryocytes. That is increased in number as well as size. And the bone marrow will not show any abnormality in other cell lines in IgP. So next about chronic IgP, 20% of IgP cases, when the thrombocytopenia is persisting for more than 1 year, we call it chronic IgP. There are primary as well as secondary causes. Secondary causes we have discussed already, that is SLE, HIV, hepatitis B, hepatitis C, H. pylori, etc. Okay. So differentiation between primary, that is acute and chronic IgP. Usually in children, we don't have much cases of chronic IgP. It is usually occurring in adults. That is when adults present with IgP, it is more likely to become a chronic IgP. Children, it is more likely to become a newly diagnosed IgP. And chronic IgP in adults, it is more common in females. A history of an infection is more common in case of childhood IgP. Then onset of bleeding is insidious, and then platelet will be much less in the case of newly diagnosed IgP. In chronic IgP, the platelet will not go very low. Okay, that's it. In differential diagnosis. So differential diagnosis, we have drug-induced thrombocytopenia. I told you earlier, heparin, antibiotics, linezolid, penicillin, all that can cause thrombocytopenia. Then splenic sequestration, that is hypersplenism, causing increased platelet destruction. That can occur in conditions like sickle cell anemia and all. Bone marrow failure syndromes. Bone marrow failure syndromes like myelofibrosis, myelodysplastic syndrome and all. Congenital thrombocytopenia syndromes like thrombocytopenia in absent radius and other conditions like hemolytic uremic syndrome, disseminated intravascular coagulation. All these are causes of thrombocytopenia. So what about the treatment? So for the treatment, we have to counsel the parents. We have to counsel the parents regarding the disease and what is expected from the disease and what is the treatment that they are planning to give. And the other aspects of treatment are the child should avoid contact sports, especially when the child is having thrombocytopenia. During the period in which the platelet count is low, when the child is sent home, the child should not be having contact sports. Contact sport means like football and all, when there is a chance of injury. So when there is a chance of injury, there can be an internal bleed and all. Okay. Then avoidance of aspirin and NSAIDs, which again affect the platelets more and cause more severe bleeding. Intramuscular injections. So when a child is having IgP, And before the child's platelet count has improved, we should not give the child any intramuscular injections, for example, vaccinations and all. We should not be doing that. And other invasive procedures should also be deferred because there is an increased risk of bleed. You can create a muscle hematoma and all if you are giving intramuscular injections. Then platelet transfusion is usually not done. So what happens in IGP? It is destruction of platelets. So what happens when we are giving more platelets? When we are giving a platelet transfusion, since it is an autoimmune mechanism, more platelets will get destroyed. As a result of that, we don't give a transfusion because that will only worsen the thrombocytopenia. But if there is a life-threatening bleed, like an intracranial hemorrhage, we have to do something very fast. We have to increase the platelet count very fast. Then we can give a platelet transfusion only in such situations. Then our goals of treatment is to minimize the risk of hemorrhage and decrease the side effects of treatment. So we have to go upon a risk-benefit balance. So whether we have to treat or not, that is the very important question in IGP. We don't have to treat every case of IGP. And we have to treat the patient and not the platelet count. So sometimes the platelet count may be only 10,000. It will be very severe thrombocytopenia, but the child may not have any bleeding. So in that cases, we don't have to give anything for treatment. Okay, we can wait that the count will improve on itself in a few days. So if the child is having some bleeding manifestations, we can treat, but otherwise we don't have to treat just because the platelet count is less. So platelet count above 20,000, and if there is no bleeding, then close observation only is required. So in a child who is having a platelet count more than 20,000 with no bleeding manifestations, only close observation. Or if there is, even if there is some minor skin bleeds, then we don't have to give anything. If there is mucosal bleeds and all, we have to treat the patient. We have to give treatment to the patient. And if it is, and in some centers, if the platelet count is below 10,000 also, they will treat the patient because there is an increased risk of intracranial bleed as the platelet count goes very less. So for children with bleeding, that is mucosal bleeds. If it is skin bleeds alone, we usually don't give treatment, we observe the patient. If it is a mucosal bleed, then we give treatment, which includes IVIG, intravascular first-line treatment that we give is steroids because IVIG is very, very costly. So does anyone know how much does the vial of IVIG cost? Nearly it costs around 15,000 rupees. So the dose is 1 gram per kg. So if it is a 15 kg child, we require 15 grams. So it is very, very costly. Okay, so it will come in lakhs. So they may not be able to afford. So the first line of treatment that we are using is prednisolone. Prednisolone, the dose is 2 to 4 mg per kg per day. And we give it for 5 to 7 days. So the treatment, you have to learn from this. This topic IGP given an OP guide is not updated. So the treatment part and all is different. It is not correct. It is not wrong. So it is not correct. It is wrong. So you have to learn from this. You should not be following OP guide regarding the treatment part and all. So prednisolone we give 2 to 4 mg per kg per day for 5 to 7 days. And we don't have to taper it. We can stop it after 5 to 7 days. Then Dexona and Metilpred pulse doses, it can be given in severe cases, but it is generally not preferred. We prefer oral prednisolone. Then about IVIG, the dose is 0.8 to 1 gram per kg. And we will see a rapid rise in platelet count in around 90% cases. Steroids will take more time to act, but in IVIG, we can see a rapid rise in the count within 72 hours, 90% cases. The side effects are, there is a risk of IVIG-induced aseptic meningitis, and thing is cost. Time consumption is okay, but cost is the major thing which hinders the use of IVIG. Then anti-D therapy. Anti-D means, I think all of you have heard about RH isoimmunization. When RH negative mother, RH negative mother has an RH positive baby. The baby can have hemolytic disease of newborn. How? What happens in an RH isoimmunization? The mother is RH negative, so she will be having anti-D antibody, and these antibodies get into the baby through the placenta, and they will attack the RH positive antigen present on the baby, and that will cause hemolysis. So that is the same concept that we are using here. So the patient should be RF positive in order to give anti-D. That means the blood group should be positive, either O positive or B positive or A positive. So we are giving this anti-D, that is immunoglobulin, and this immunoglobulin will attack the RBC of the patient. That is the D antigen which is present in the RBC of the Rh positive patient, and that will cause some hemolysis. And so the spleen macrophages will be busy with this RBC. They will be busy with destructing this RBC so that the platelets will be spared. That is what is the mechanism that we are using here. So we are inducing a mild hemolytic anemia in order to save the platelets from destruction. Okay. So mainly we give steroids and IVIG. Second line drugs for children who are having persistent IgP, that is lasting for 3 months or more, and who are not responding to the first line therapy, we may have to go to second line therapy. If there is a significant bleed, like mucosal bleeding, and if it is affecting the quality of life of the child is not able to play as usual because of the risk of, there is a fear of bleed, whether there will be hitching, the child will be hitching head and having intracranial bleed, and all this are affecting the day-to-day activities, then we may have to go for second line therapy. And it includes Dapsone, Danazol, and Azathioprine. So these all are immunosuppressants, and they can act against the antibodies, and they will inhibit the antibodies, and that will save the platelets. Then newer drugs, these are the preferred ones, like rituximab. So if we are able to get these drugs, these are the preferred ones because the other drugs have many side effects. Rituximab, L-Thrombopag, and Romiflostim. Rituximab is a monoclonal antibody to CD20, and L-Thrombopag and Romiflostim are thrombopoietin receptor agonists. That means they will act like thrombopoietin, and there will be increased platelet synthesis. Okay, so these are the newer and the preferred drugs if they are available in as second line drugs. First line drugs is always steroids, IVIG, and anti-D. These are the drugs which has to be given as first line for any patient. If the patient is not responding to that, only we go on to the second line drugs. Then we can do splenectomy also in very severe cases, not responding to any drugs. Then we can go on to have splenectomy. And in complete remission occurs in around 80% of cases with chronic IgP. But splenectomy is always associated with severe infection. So we have to do it only as the last resort. So mainly about the treatment of IgP. When a child is presenting to you with skin bleeds alone, you don't have to treat the child. If there is significant bleed in the form of mucosal bleeding, or the platelet count is going very low, that is below 10,000, then there is a risk of severe bleeding. So in those cases only we treat the child. Otherwise, we just observe the child and we repeat the platelet count and we see if it is improving or not. Advise the parents to avoid contact sport, avoid NSAIDs, aspirin, avoid intramuscular injections and other procedures. And if the platelet count is improving on its own, then it's fine. If it is, if there is a bleeding or if there is very low platelet count, we have to give steroids or IVIG. And in Rh positive patients, we can give anti-D also. So this is the first line therapy. And after the platelet count is improving, we send the child home. And then we monitor the child. And if it is resolving within 3 months, the platelet count has returned to normal, there is no further bleeds, that means the child has the IgP has resolved. And if it is less than 3 months, then it is newly diagnosed IgP. If still the platelet count is low and in between there are bleeding manifestations, it is going beyond 3 months, then it is persistent IgP, but it gets resolved within 1 year. If it is going beyond 1 year, it becomes chronic IgP. Okay. So I hope everyone understood. Any doubts? Anyone? Anyone having any doubts? Any of the slides, if anyone didn't understand, please tell me. Okay, അപ്പോൾ നമുക്ക് സ്റ്റോപ്പ് ചെയ്യാം.
Okay, ma'am. Thank you, ma'am.
എനിക്ക് സെൻഡ് ചെയ്യണം.
WhatsApp ചെയ്തേരാം, ma'am.
Yes.